Welcome everyone to the December 3rd webinar, the Addiction Toxicology Case Conference. Today we have a special session, updates in novel psychoactive substances and drug adulteration. This is a case-based discussion. As previous, this is a partnership between the American College of Medical Toxicology and American Society of Addiction Medicine. Please visit the webpage at acmt.net for prior Addiction Toxicology Case Conference Webinar Series FAQs. We have some great information from previous webinar series embedded in the webpage from ACMT. I'm one of the moderators, Timothy Wiegand, Director of Addiction Toxicology and Associate Professor of Emergency Medicine at the University of Rochester Medical Center in Rochester, New York, and my co-moderator is Dr. Gloria Bashevitz, the Medical Director of Strong Recovery and Professor of Clinical Psychiatry, Department of Psychiatry, also at the University of Rochester Medical Center in Rochester, New York. We have a distinguished group of panelists today, Dr. Jeffrey Brent, MD, PhD. He's the Distinguished Clinical Professor of Medicine and Emergency Medicine at the University of Colorado School of Medicine and the Colorado School of Public Health in Denver, Colorado, and a close colleague and friend over the years. Dr. Joanne Lace, MD, Attending Physician, Division of Addiction Medicine, Hennepin County Medical Center, Minneapolis, Minnesota, also close colleague and friend. And Dr. Barry Logan, PhD, Executive Director, Center for Forensic Science Research and Education, Chief Scientist, NMS Labs, Willow Grove, Pennsylvania, friend, colleague, and panelist for ACMT and NISAM Tox panel in the past. We certainly appreciate his contributions. And Dr. Ross Sullivan, Assistant Professor of Emergency Medicine and the Director of Medical Toxicology and the Upstate Bridge Clinic at the Upstate University Hospital, Syracuse, New York. Before going into the cases, we have an upcoming event that I'd like to announce, the 2021 Virtual Seminar in Forensic Toxicology. This follows a series of forensic toxicology seminars. The 2021 seminar is a look forward at new psychoactive substances and a look BAC at ethanol. This is December 16th and 17th, just around the corner. Virtual content. It has some excellent content. Some of the panelists attending are going to be involved in presenting for this conference. None of our speakers have any conflicts of interest to disclose. And let's just jump into case one. Let me tell you about some of the things I've tried. This case features a 29-year-old male with an extensive history of substance use disorder and addiction. He is brought into the hospital by EMS and police with altered mental status and tremors after trying to rob a bank. He has tachycardia, 110 beats per minute. He has mydriasis, he is diaphoretic, and he is sweating, but he's pale. He also has some white plaques on the ventral surface of the tongue and 3 well-defined areas, kind of square-shaped, and some white residue in both areas. This is under his tongue and his mouth, and then he's got some whitish residue in his nose. And the first and second digits of his right hand have blisters and some ulcerations and red and blackened areas in the tips of his other hand and his first fingers are findings as well. You can see the whitish areas in his mouth, these plaques that he has. He was arrested after leaving a bank. He passed a letter to the teller and walked out with money and then got arrested by police. And at intake, the police note he's very tremulous, he's sweating, that he had abnormal speech and very dilated pupils, and so they brought him into the emergency department. They called an ambulance. In the ED, he's tachycardic, sweating, his mydriasis, his tremors, his some dysarthria, he's got the plaques under his tongue. His labs show an elevated white count, an elevated creatine kinase. His hemoglobin is normal, his sodium, potassium, chloride, bicarbonate, renal function, that's all normal. Urine screen is pending. Patient is given 1 milligram of lorazepam intravenously, and fluids are started with thiamine and dextrose. And he reports he had run out of cocaine. He'd been on a crack binge. And initially, he crushed and insufflated, sniffed, bupropion. And after that, he was taking 300 milligram XL bupropion tab and keeping them under my tongue because it tasted like Coke. And so he had actually been on this binge for several days, and he says he needs some sleep. He'd been apparently peeling off the outer coating of these bupropion 300 milligram XL tabs and holding them like lozenges and then rubbing his tongue over them until they dissolved. And this had been going on for about 12 hours. It took a while for each of them to dissolve, but he is unsure of how many he's taken this way, but he says more than a few. And that's actually what the whitish plaques are from, where he had kept like 3 of them at a time and was just rubbing his tongue over and over them as he had the absorption. My question is, first, what would you do clinically for this patient? He's already gotten some lorazepam and fluids. What are the toxic effects of bupropion, and what do you think about the insufflation and sublingual use by this patient? I'll start with Dr. Brent.
Well, yeah, we certainly see a lot of people that are abusing bupropion, and they present not terribly different from this patient. They have a primarily sympathomimetic picture. Bupropion's primary action is that it inhibits dopamine uptake. And so it looks basically like a dopamine uptake inhibitor. That's why people like to use it, but it also inhibits norepinephrine uptake. And that's where we see a lot of these effects. So we treat it basically like a sympathomimetic, rely heavily on benzodiazepines and, if necessary, phenobarbital. And then, observe him, of course, because of the high likelihood of seizures in a patient like this. And then once we get him stabilized, we go on. We can deal with the more chronic aspects of his care.
Very good. What I typically see bupropion, you certainly have the adrenergic findings in the reward, which is why he had this rather impulsive use. But it also looks quite serotonergic. I mean, he has myoclonus, hyperreflexia, and I'm wondering, to me, the bupropion toxicity is a mixture of serotonergic and adrenergic toxicity. There's more hallucinations as well. Can you comment a little bit on that?
Yeah. This is an area that I'm really interested in, because if you look at the science behind bupropion, it's pretty weak in terms of its serotonergic effect. Yet it typically does present with things like myoclonus, rigidity. And so there's, it suggests that there's some sort of crossover between its dopaminergic and norepinephrinergic effect and what looks clinically like serotonergic effects. But pharmacologically, it is not a very serotonergic molecule.
Yeah, very interesting. Dr. Sullivan, do you have any comments?
No, I absolutely agree. And sometimes you can see people who take this in combination with other serotonergic medications even have, almost a serotonin syndrome-like, picture. So absolutely agree with everything Dr. Brent said.
Dr. Lace, have you seen bupropion abuse and intoxication?
I actually don't see as much of it as I used to. I think a lot of the newer psychoactive drugs were more appealing to people, but I see that his creative use of the medication is really to speed up the onset of action, which is what is the addictive property of the drug, is how rapid the effect happens.
Right. I see bupropion, which is sometimes referred to as poor man's cocaine, used often in settings like an inpatient treatment program, incarceration. I actually was told by one individual that they learned about the euphoria because while she was incarcerated, in order to avoid cheeking the meds and then passing them off, the staff crushed several of them, including the Wellbutrin. And she said when it was crushed, she had a lot of euphoria instead of taking it as a sustained release or extended length, and this was while incarcerated. So I thought that was very interesting. Dr. Bashevitz, do you have any comments about bupropion abuse? Do you see that in the patients you're treating?
Oh, yes, quite a bit, more so in the inpatient, like you're saying. And certainly that story about running out of cocaine and going to Wellbutrin because that's all you've got is a very, very common one that I've seen. And I've known some inpatient units that will mix up the immediate release bupropion in some applesauce or something, hoping to prevent this abuse of it. Yeah.
Interesting. Dr. Logan, do you have any comments? Are you seeing this forensically, either in driving or any of the other laboratory work you're doing? Do you have any other comments? Dr. Logan, you're muted still.
Actually, I'm sorry, I'm having some technical difficulties here. Bupropion is typically a relatively minor finding in most of the postmortem toxicology cases, and really don't see it in impairment cases either to any significant extent, at least not on its own. Most of the deaths involving bupropion tend to be, as has been commented earlier, when they're present with other serotonergic drugs, and there's evidence of serotonin syndrome or something similar.
I think the only deaths that I've seen with bupropion have been really large overdoses, and it can be catastrophic when taken as a, in a suicide attempt. Most often when it's a misuse or abuse, it's, the seizures and other toxicity that can be treated fairly readily as long as recognized. All right, well, let's move along. So the patient is able to relax with several doses of parenteral lorazepam. In addition to the described findings, he had marked hyperreflexia at the patella and sustained clonus at the ankles bilaterally. The tone and his other excitatory symptoms improved with the benzodiazepines and fluids. He's tangential, he's perseverated on how much the Wellbutrin tasted like Coke. They feel like it too, but then there too, he said moreish, and then this stuff happens. I think he means it's hard for him to stop once he starts using like this, much like he crack cocaine. And then by this stuff, he does bizarre things. He ends up robbing banks or doing things that he gets in trouble with. The patient recalls a provider from multiple previous admissions and asks, "Remember when I was here for MDPV?" Since 2010, he's either been seen in the ED or admitted to the hospital, including the ICU, for MDPV-related intoxication, methadone intoxication, 25I NBOME intoxication twice, after which he progressed to using more standard substances such as cocaine, crack, and heroin, and subsequently fentanyl, and a host of other drugs, the majority of which he bought from the dark web. He'd been arrested in 2010-11 for selling or conspiracy to distribute methadone and methadone, and he said, and I used a lot too. My questions are, what are MDPV, methadone, and methadone? What is 25I NBOME? And then maybe we can get into some trends related to the designer stimulants over the past 10 to 12 years. I know we have some slides from Dr. Logan and Dr. Brenda coming up here. But before I move on to those slides, just in general, what are MDPV, methadone, and methadone? Dr. Logan, can you comment?
Yeah, so these are designer stimulant drugs that started with cycles maybe 10 years ago, 11 years ago now. Previous to that, most of the stimulant drugs we saw were the traditional amphetamines and then MDMA in the 1990s. And things were pretty quiet until about 2010 when some other compounds started appearing, particularly in the cathinone series, which methylone is a member of. And after that, there've been a series of chemical compounds and chemical families with mostly stimulant effects, some of them more atypical serotonergic effects, more like MDMA itself. And so the pills that are on the street today that are being sold as ecstasy are frequently a mix either of MDMA plus a cathinone. I'll talk in just a little bit about some of the other members of that series. MDPV is a pyrovalerone, which is less entactogenic and pathogenic and more like the traditional amphetamine type profile. But today's stimulant profile in illicit drug markets is pretty diverse. In fact, cathinones are amongst the most frequent category of new substances that are monitored by EMCDDA.
That's the European Monitoring Center for Drugs and Drug Addiction, I believe, right?
That's right, Tim. Yep.
And methadone in particular was very popular in Europe and the UK in 2000, preceding the 2010 introduction in the United States. I mean, from what I recall, these three were the colloquial bath salts that started showing up in the United States in 2010 approximately. Is that consistent with your experience?
Yeah, that's right. And other drugs in this series that are not in the cathinone group, but more related to MDPV was alpha PVP. That was pretty popular in about 2012, 2014.
I recall that replaced MDPV, and there was one smoke shop in our area that was selling it as ladybug attractant. The prior product was a glass cleaner, a bath salt, and that had MDPV in it, and then the replacement was ladybug attractant that had this alpha pyrovalerone. Dr. Brent, what was your experience with these cathinones early on, and as the couple of years progressed after?
Well, I think it was pretty much the way Dr. Logan has elucidated. It's we went initially as amphetamines became a little bit more creative. We got the MDMA drug, and its various analogs, and from there, then the so-called cathinones or bath salts became more prominent. And so I think this is kind of the trend. I think we're just moving into an era now where actually, at least from what we can see, methamphetamine is the primary stimulant that's being used, and it's kind of circled back to basics.
Yeah, no, that's definitely, we're seeing more methamphetamine up in the upstate area, more in the rural areas. And then when people are, what they call it Molly instead of ecstasy, I guess it's changed. Using Molly, people think that they're getting MDMA, and sometimes they are, but more often they're getting a mixture of cathinones, other stimulants, and methamphetamine has been found in the Molly. But for a couple of years, methylone was a very common chemical found in what was sold as MDMA or Molly, but then it seemed to disappear. I think there was some scheduling looseness around this, a gray market, depending on if they were sold as research chemicals or not. Dr. Bishevitz, do you recall when the bath salts or the MDPV methylene methadone started hitting Rochester?
I think it's about what you said, right around 2010. And we saw quite a lot of them too, especially in ED. They often ended up in psychiatric ED with very severe behavioral symptoms. But I agree with you, it's been mostly methamphetamine around here.
Yeah, the MDPV, I think, was also nicknamed Super Coke because it actually has a more potent binding at the same sites as cocaine. So a little bit different than an amphetamine, even though I think it's a pyrovalerone. But the excitatory symptoms that I saw with some of the MDPV intoxications, if people would overdo it, were incredible. Really severe sympathomimetic intoxication. Dr. Sullivan, what's your experience in clinically taking care of patients with intoxication, MDPV, or any of these others?
Yeah, I was, practicing heavily as a new, graduated the toxicology fellow in around 2010 or 11. And these people were very, very sympathomimetic, and in my experience, far surpassed, what I would see with cocaine users and even some amphetamine users. The degree of agitation, hyperthermia, tachycardia, high blood pressure were all on a level that was very severe. So, clinically it was, they're difficult to take care of, but in some ways you had to be very heavy-handed, and using high amounts of benzodiazepines, maybe other medications, even maybe sometimes antipsychotic if you had to acutely. But the rapid control of these people were very important. And it was kind of like that, when you get taught about how PCP acts and all of these are different, slightly mechanistically and structurally, they were very aggressive and actually been very sick. And we saw so many of these in 2000, I feel like 11 and 12, that it became almost towards the end, we were just expecting it, almost commonplace. Interestingly, this happened with this explosion of synthetic cannabinoids, which I know is a different issue, but really compounded the local and epidemic effect of these.
Yeah, you had, well, Syracuse, they called it spike, but the rest of the world calls it spite, or K2 or synthetic cannabinoids. That was also going on. It became, people overlooked often other conditions. Got another agitated bath salt patient coming in, and she really had to take a step back sometimes. This patient in particular had a 3 or 4 day prolonged excitatory syndrome after one of his MDPV intoxications that was very difficult to control. And, in retrospect, it would have been much more aggressive and probably just intubated and had on propofol. But severe rhabdo, myoglobinuria, renal failure, dehydration, and quite a few days of recovery where he was hyperthermic and really severely intoxicated. Dr. Lace, do you have anything to add? Maybe can you tell us what 25I NBOME is?
Yeah, so 25I NBOME is in the class of the 2C novel drugs it's a substituted phenethylamine. And so there's different neurotransmitter profiles of all these drugs, whereas some seem to be more agonist at norepinephrine and dopamine, some to be more serotonergic. And this is one that has a little bit more serotonergic properties.
One of them, known as an ultra potent hallucinogenic amphetamine, and was sold or misrepresented as LSD because it was available in sub-milligram doses, along with 25I, which is an iodinated version of the 2C, and then an extension N-benzoorthomethoxy chemical group, and I can show an image of that. There's chloro groups of 25C, bromo group 25B, and a number of other analogs that made their way into the illicit drug supply, mainly either misrepresented as LSD and blotter paper, or just simply sold by themselves through the internet or the dark web. Dr. Brand, what differences in intoxication? If someone had, an LSD and taken a couple of extra hits of LSD and blotter paper and done the same thing with something that was adulterated with the 25I compound, what differences in clinical effects would you see?
Well, from my experience, the N-bombs are very, very potent. The effects are much more severe than what you would see with LSD. They're both serotonergic agents. N-bombs are actually developed as research chemicals to probe the serotonin receptors. And 25I is very, very highly selective for 5-HT2A receptor, which is the receptor that's associated with the most severe aspects of serotonin syndromes. And that's exactly what I have experienced clinically. You see patients with really severe serotonin syndrome, severe hypothermia. Often they have to be intubated. They have profound status clonus, even without provocation. And this is something that you don't see with LSD. LSD certainly is a serotonergic drug. It certainly acts at the 5-HT2A receptor, but it is a much more gentle drug in terms of the degree of serotonergic effect that it causes.
Yeah, this is something where I would have a group of 6 individuals. 5 of them would maybe take a single dose, and then come to the 6th individual who was hyperthermic and severely agitated, but had maybe done a double or triple dose, something that they had done in the past with LSD without any problem. But so even double or triple dosing can have severe effects. Dr. Bishevitz, we have a couple of Q&A or chat. Is there anything that you wanted to bring up from our audience? And please, audience, ask questions via the Q&A, ideally. Anything in the Q&A, Dr. Bishevitz?
You're on mute.
Oh, sorry. So the question is, apparently beta blockers have no role in acute treatment. Why is that?
That's a good question. I can start with that, but it's masking some of the symptoms. It's really not treating the excitatory intoxication at the core. The tachycardia is the marker that there's a hyperadrenergic state or excitatory state. It doesn't get to the treatments, which is central and can be only really dampened down by inhibitory treatments like GABAergic agents, phenobarbital, the benzodiazepines, propofol, adjunctive agents like dexmedetomidine, for severe agitation, maybe even ketamine, but the beta blockers are just going to mask that effect at the heart, but you still have the underlying excitatory effects. And Dr. Brent, you want to add anything to that?
No, I think that's true. I think, I wouldn't say that beta blockers have no role, but they really, if they do have a role, it's a minor role, because what you really want to do is control the underlying pathophysiology. And, certainly even through the process of doing that, if you have a very unstable tachycardia, you might want to use a little. I'd recommend using something very short acting, like that you can easily titrate, like esmolol. But it certainly is not a first or even a second line drug for these agents.
Yeah, it's similar to alcohol withdrawal, where if you don't treat the withdrawal, the tachycardia will persist. If somebody has an unstable rhythm because of cardiomyopathy, maybe you would add a beta blocker. But that's good. Let's move on to the trends. Before trends, though, I wanted to illustrate how structurally we have bupropion on the lower left, which is a beta keto perachloral and tertiary butyl phenethylamine. So it's actually an amphetamine at its core. Here we have in the middle methadone, which is it's a methyl group off the back of the phenyl ring, and then it's essentially beta keto methamphetamine otherwise. Methylone without the beta keto group is MDMA. I think that's very similar effects to MDMA, other than it's a little less potent. And MDPV is a methylene deoxypyrovalerone. The pyrovalerone is the group with the nitrogen and the ring off and the alkyl ring here. And then you see 25I and benzoyl orthomethoxy. This is the orthomethoxy here, and the two, they call these the 2C. They look like kind of wings coming off. The iodine hanging off the back of the molecule is where you get 25I, 25C, 25B, different variations and subtle difference in potencies and clinical effects, but basically all extremely potent, ultra potent serotonergic drugs. So, but they all have this phenethylamine backbone to some extent. Dr. Logan, you had some data on surveillance that I'll let you run us through.
Sure, Tim, if you want to jump back to the previous slide just for a second. So looking at methylone, all of the structural tinkering that the clandestine chemists are doing is around that amine, changing the alkyl substitutions and the length of those chains. And then on the carbon adjacent to the nitrogen, the length of that CH3 on the bottom there is lengthened and sometimes with branched. So that's what generates the series of the so-called loans or cathinones. So if you want to go on to the next slide, I'll talk a little bit more about the process that we use for surveillance in illicit drug markets a little later, but this is some data from when we started monitoring the cathinones starting back in 2012 when methylone was the emergent cathinone. And these are the number of death investigation cases in which the drug was detected from our partner NMS Labs. So you can see that for a couple of years, methadone was the predominant cathinone in this class. Different populations use it. It's popular amongst college age students, and particularly popular in certain drug subcultures like electronic dance music, festival attendees, typically looking for MDMA, but frequently either knowingly or unknowingly purchasing something else. So for a couple of years, methadone was the predominant cathinone. It was scheduled in 2014, and you can see that for a brief period of time, ethylone, so the ethyl analog, started to predominate in those markets. Ethylone in turn was scheduled, and butylone emerged to a lesser degree, but N-ethylpentalone became the favored member of this class in these particular drug-using subpopulations for, again, a couple of years. Once that was scheduled in 2019, Utilone replaced those drugs. And Utilone has significant more potency, as does N-ethylpentalone than methadone, which started this series. So there does seem to be some actual design in terms of creating more potent, more dopaminergic drugs as compounds are scheduled. And spoiler alert is that we've just started to detect what we think is the replacement for Utilone. In about a dozen cases in the last 2 months, we're seeing NN dimethylpentalone. So a return to the pentyl core. But a typical life cycle is anywhere from a year to a couple of years for these drugs.
This doesn't include the data from MDPV, methadone, or does it?
It does not. No, this is just the members of the cathinone, the cathinone series.
Okay. And then you have...
And then, yeah, we do look at a variety of different data sources or data channels in terms of trying to identify and in some cases predict what new drugs might be emergent. This was a paper we published earlier this year with some colleagues from the National Drug Early Warning System, looking at mentions of substances on Reddit and other social media platforms. And so Utilone, you can see there was chatter about it on some Reddit subthreads in mid-2018. And then the red line, the pink line, reflects when we first started detecting it in toxicological samples. So you can see that there is some heads up or over the horizon intelligence on some of these drug user forums and drug user chat groups that might give us an indication of what may be coming down the pike. So we're trying to be a little more deliberate and spend some more resources in analyzing some of the web activity on social media sites to give us an early look at what might be on its way. Same with N-ethylpentalone. You see that the online activity preceded its actual appearance in toxicological samples.
That's interesting, and then that influences potentially your targeted analysis in forensic surveillance.
Yes, I mean that's a whole other topic really in terms of whether the lab is doing a targeted or non-targeted analysis. One of the techniques that we use is we use a non-targeted acquisition, which basically collects information about everything that might be in a sample, whether we know of its identity or existence or not. So the data are locked up. And then we can subsequently, when we know about the appearance of a new substance, go back and reprocess data to find out when earlier cases might have occurred and to try to get back to those sentinel cases. So that's been an effective strategy also.
Okay, thank you. That's excellent. Let's move along with the patient. He improves overnight. He'd been given olanzapine after the benzodiazepines, which improved his thought content, and he was able to sleep. He's again seen by the Addiction Toxicology Service and is interested to discuss the current state of the drug market. As he's talking, he's noted to have a nicotine patch in his mouth, which was removed. He is in an opioid treatment program receiving methadone at 50 milligrams a day. He's also prescribed gabapentin, ibupropion, valproex, hydroxyzine, and diprazidone, 2 caps with meals. Patient describes stopping the cathinones other than the bupropion, meaning his methadone, methadone, and MDPV, which he admits to frequent crushing and insufflating or holding sublingually. He prefers crack, but when he can't get it or runs out of money, he uses more of the bupropion. Has ordered liquid LSD off the dark web and some LSD analogs, and a few of the 2C compounds and several of the N-bomb compounds, but preferred 25I until he double dosed and had severe sympathomimetic and serotonergic toxicity requiring an ICU admission. He's ordered etizolam from his cellar in Italy, mentions that he's trying to avoid the benzodiazepines because he's concerned about the withdrawal from them. And he says, but I like experimenting. When I used 25I N-bomb the first time, I was able to understand string theory. The question is, what types of novel synthetic hallucinogens besides the M-bomb compounds have been available via the dark web? And then what are the most commonly encountered? He mentioned LSD analogs, and are there any differences in effects? Again, I'll go to Dr. Logan first. What have you seen, and what is detected forensically?
So yes, in this category, and I should also comment just on the N-bombs that they, whereas we really have never seen a fatality due to an overdose of LSD, there are a number of recorded fatalities from the N-bombs, frequently taken in combination with other more serotonergic drugs, but that seems to be a significant risk for the N-bombs. For other synthetic hallucinogens, besides the drugs we've already talked about in the N-bomb series, we have seen LSD analogs, other oxy analogs, and alkyl modifications. And then ketamine analogs are the most recent drugs in this series to appear.
Like methoxetamine, and I think there's some phencyclidine analogs we've seen in upstate New York. Dr. Sullivan, what have you seen in terms of novel hallucinogens and I guess the aryl cyclohexamines, which the ketamine and PCP analogs?
Yeah, we see, not to totally change subjects, but, here we see quite a bit of kratom or midragina. People talk about its opioid properties, but it does have some stimulant or psychoactive properties at different doses. We're seeing that, quite a bit. DMT, we're seeing, I still tend to see, or just dimethyltryptamine, which we still see, which is has serotonergic hallucinogenic effects as well. And as you mentioned, some of these other ketamine-like things that we're seeing, which I might not be necessarily privy to to the actual name or types, but we're seeing, a lot of different things kind of come through our area. We used to have things like 2-bromo dragonfly, or these, these MEO DMTs, or these are very, these methoxy dimethyltryptamines. Certainly this type of patient that you have is a sophisticated user, and there's a lot of different things that the patient can be using on the internet. But, those are the things that, I'm most often coming across in terms of people getting some novel things off the internet.
Yeah, it's interesting. We've had some occasional, the self-described psychonaut, meaning explorer of consciousness and psyche, using chemicals. I think it really made, originally attributed to Alexander Shogun, and who authored the book Phenethylamines I've Known and Loved, Picol and tryptamines I've Known and Loved, which he described his experiences, and then the synthetic methods for these chemicals. And it's a lot of individuals that are self-described psychonauts. I recall seeing a graduate student who was blind, but wanted to experience hallucinations while blind, wasn't sure what they would be like. And he had, I don't recall the particular hallucinogen that he had ordered, but he'd ordered off of the dark web and had some serotonergic effects and some trauma from falling, but very interesting reasons why people are using these, and the availability. Also, the buyer caveat, and poor buyer will beware, because sometimes people don't get what they're ordering, what they think they're ordering. Dr. Lace, what have you seen in terms of novel hallucinogens in Minnesota?
You know, they're actually not very prevalent in the population that's coming to the hospital. It's really methamphetamine and opioids right now.
I think there was a case in Minnesota around 2010 where someone had ordered what they thought was like methadone or something for a party, and gotten the 2-bromo or the bromo dragonfly, which is an ultra potent hallucinogen, and given everybody a dose that would be consistent with a methadone dose, like which is 100 or 150 milligrams, but the bromo dragonfly potency is like a 2 or 4 milligrams. So they had given a number of individuals a massive overdose of the a different drug unintentionally, and there were some fatalities around that. And there's other unfortunate situations where that has occurred. So a lot of danger in some of these. People really don't know what they're getting or get the wrong chemical. Dr. Bashevitz, what has been your experience? Have you encountered patients with novel hallucinogen use, and what types of hallucinogens?
The most common types of hallucinogen have been the N-bomb and also the DMT. Have very few people claiming that they use LSD anymore. And as far as getting things from the dark web, a benzo, etizolam, seems very popular because they think it won't be found.
Yeah, we're seeing a lot of designer benzodiazepines. So thank you. So the patient is kept in the hospital for 3 days. The CK had risen. He had some mild acute kidney injury, which improved with fluids. He's kept on the methadone. The bupropion was DC'd. He refused to take the valproic acid because they gained weight on it. He said, was kept on the ziprasidone. He's discharged into police custody, but he plans to follow up with the opioid treatment program when he's released. Any further comments or questions from the panelists? And did we have any additional comments or questions from the audience, Dr. Bashevitz, before moving on to case 2?
Nothing new from the audience.
Any panelists have anything further they want to comment regarding this case?
Just a follow-up comment on your observation about benzodiazepines, Dr. Wiegand. That's the most prevalent class in terms of proliferation of new drugs right now. A lot of them are triazolobenzodiazepines, so more similar to triazolam, pretty potent, and all showing up in all kinds of counterfeit type pills, things like Xanax bars, but also in opioid tablets like fake OxyContins.
Yeah, that's a good point. I think almost a day doesn't go by where it's either inpatient or outpatient. We have a patient using pressed Xannies, and so my next case is what's in the drug supply, and we have some slides from Dr. Logan again that you can run through for us.
So I did mention NPS discovery a couple of times. That's the model that we use for this landscape surveillance of illicit drug markets at our research center here. So I'd encourage you, if you're interested in this, to go to the website. We have reports there of analytical information regarding the structure and analytical behavior of the compounds we identify, but also we put out regular trend reports and public health alerts related to outbreaks, whether it's in vulnerable populations like prison populations or street drug using populations, particularly associated with the appearance of new drugs in the drug supply, where users are frequently getting drugs that may be a lot more potent or in doses that may be a lot greater than what they're used to. But generally, we collect as much information as we can from web monitoring to try to understand the universe of compounds that might be out there that people are talking about online, that illicit sellers are offering for sale online. We then start surveilling for these analytically in a number of different populations. We have great collaboration right now with ACMT and the Toxic Registry, where we're starting to get biological samples from ER admissions where the syndromic information is being collected for toxic and getting toxicological confirmation of the drugs and sometimes the adulterants that are contributing to those presentations. And then once we know that something is in the supply based on these sentinel cases, we start a lot more comprehensive monitoring in postmortem populations, impaired driving populations. We're now working with a number of local health departments on drug checking programs with drugs that are retrieved from individuals reporting adverse effects who don't go to the ER. So just trying to gauge which drugs actually get some traction and start to make significant contributes to adverse effects and harms. And then to report all of that information out to stakeholder communities. So you are invited to sign up on the website and you can receive those alerts as they come out. And then to use that information in terms of these waves, like I showed with the cathinones, in terms of what might be coming next, to try to do kind of an NPS forecast based on what we know about tinkering with structure activity relationships and scaffolds to either increase potency or to impact half-lives that are taken into account when people make these new drugs. So that gives us some insight into these trends in stimulant drug categories, but also in opioids. A lot of our focus for NPS discovery right now is on novel synthetic opioids, particularly the so-called nitazines, isotoniazine. Protonidazine is an emerging one, and then there's a couple of new potent synthetic opioids in that class that have appeared just within the last couple of months. If you want to go on to go ahead. Oh, so I think maybe Jeff, do you want to talk to this?
Oh yeah, project? Sure. I'd be glad to. You know, Dr. Logan has, mentioned the Toxicology Investigators Consortium. For those of you who are unfamiliar with it, this is a multi-center research program that I run along with Paul Wax, and we have this one particular study, which we call the Fentolog study. Alex Manini is from Mount Sinai, is the primary investigator of that study. But what we've been doing is collecting biological samples of patients who present with apparent opioid toxicity. Dr. Logan's laboratory has been doing extensive analyses on these samples, and we're also collecting associated clinical information. And it's been an extremely enlightening exercise to get a sense of what's out there. One of the first things we found is what I think a lot of people here realize, that heroin is not heroin anymore. For the most part, it's fentanyl, except if you're living primarily up in the Northwest. But what is also true is nobody just gets a single drug anymore. What we're seeing is combinations of drugs for people who think they are using an opioid and injecting an opioid, whether they know they're using fentanyl or whether they think they're using heroin. They are getting lots of other things associated with it. And that can include designer benzodiazepines, it can include things like xylazine, old drugs, like we see a lot of tramadol. Probably about 20% of our samples have tramadol in them. And we're beginning to see, as we were talking before about stimulants, we're beginning to see more and more PCP find its way into the samples. And so that seems to be emerging. And interestingly, while we're talking about PCP, we also have found tenocyclidine. Tenocyclidine, if you're not familiar with it, is a PCP analog, also like the N-bombs, originally developed as a research chemical, but is a much more potentially potent form of PCP, and will probably not trip a PCP positivity. Just looking at its chemical structure, I wouldn't think it would trip PCP positivity on a drug abuse screen. Lastly, let me just mention one thing that Dr. Logan had alluded to, and this is the emergence of the nitazines. Nitazines are really scary drugs. They are opioids. Most of them were originally developed as for research chemicals, and the clandestine chemists have found those old articles and are now making them, and we're beginning to see them. Nitazines typically are active at the mu opioid receptor. They're probably about 2 orders of magnitude more potent at the opioid receptor than fentanyl, which probably will make them about 10,000 times more potent, therefore, or something like morphine. These are, and they're non-biased. They are fairly uniform opioid receptor agonists, and they don't have anything that would suggest that they would have less toxicity than standard opioids, but they're a lot more common. We're seeing isonitazine. We've had 2 cases of a drug called metonitazine. Both of those have presented in cardiac arrest. I think now that the fentanyl analogs are basically prohibited, since they've been now classed as a group, that we're going to be seeing more and more of these nitazines.
Thank you. Yeah, there were clusters of isonitazine in the past, but that's a couple of years ago. I think that looking at the announcements and emerging literature, that nitazine are really concerning, as you mentioned. So let's move ahead with this case. We have a 28-year-old female presents in the area detoxification facility to get help coming off alprazolam and perks. She's taking 4 to 6 of what she calls 2 milligram pressed alprazolam bars a day, along with 30 milligram oxycodone IR, she calls it perks. And she insufflates 5 to 6 of them a day. Her urine screen at the intake is positive for benzodiazepines, fentanyl, tramadol, and THC. She also reported some cannabis use. She's startled that she has no oxycodone in her urine and is surprised and anxious there is fentanyl. And tramadol, she asks, what even is tramadol? The patient's been buying pills from someone off the street. She reports she knows someone is pressing, she calls them the Xennies, but she did not realize the oxycodone was counterfeit. She reports having 2 recent episodes where someone almost had used naloxone on her, and her sister found out, which prompted her to enter the detox to get off this stuff. So we've got about maybe 10 minutes left, a little under 10 minutes. So what is in the counterfeit pressed alprazolam supply? And then why are the synthetic counterfeit materials pressed to look like these Xanax bars, which seem to be probably the most common, and then oxycodone? What is commonly historically found in the counterfeit oxycodone tablets? And we'll start with, I guess, Joanne, why are the synthetic counterfeit materials pressed to look like Xanax bars? What do you think, Dr. Lace?
I think that the shape of the bar was a pretty easy to replicate pressing mechanism, with it being a powder bar, and then a fairly simple symbol on it. I haven't historically, or I haven't been seeing that as much recently with the Xanax. What I've been really seeing is what everybody's calling perk 30s. And they've just gotten to the point where they just realize that it's fentanyl that is what they're getting. And that's sort of like what, it's very apparent to everybody that perk 30s really aren't oxycodone at this point.
Right. I think it's also alprazolam sells itself. It's probably one of the most euphoric benzodiazepines. People really like it, name recognition, and so they press it. Looks like alprazolam along with maybe it being simple. In our area, we found oxycodone. We had a cluster of haloperidol and chlorpheniramine that was in a certain cluster of oxycodone and 30 counterfeit tablets, but most often it's simply fentanyl. Dr. Sullivan, do you have any comments what you found in the Syracuse area?
I mean, certainly the fentanyl was the thing that we find most often in these pressed Xanax bars. There have been escapes, the name of some of them you'll remember. We've had an increase of some of these laboratory benzodiazepines that are quite potent. So they're not alprazolam, but they're I can't remember. I think maybe etitazolam or some of the other ones that we're starting to see that people are saying are Xanax bars. and are not, or Tazolam or these other ones, but mostly fentanyl, but also an increasing amount now of some of these other newer or brought back to life benzodiazepines that are pretty potent.
Yeah. People also are beginning to realize that some of them test positive for benzo and then confirm negative, and are very savvy, saying, "Oh, I always am. It's a false positive. It's a false positive." Dr. Bishevitz, have you run into that?
I wish I had a nickel for every false positive I ran into. Yeah, absolutely.
Dr. Logan, do you want to run through what are you seeing in these pressed alprazolam pills, or what do you think? And the same for the counterfeit oxycodone?
Yeah, they're predominantly atizolam, which has been around for 4 or 5 years now, but increasingly clonazepam. A year and a half ago, maybe flualprazolam was the thing that everybody was looking for, and bromazolam. So again, triazolobenzodiazepines, but every so often we'll find them that although they're pressed Xanax bars, they are fentanyl. They contain fentanyl.
So the patient could use one of the bars of alprazolam before coming in. She's slightly drowsy and a perk, normal heart rate and blood pressure, no other medication use except for occasional gabapentin if she cannot find enough of the pressed Xanax, she says. So I question, Dr. Sullivan, what's your plan for detoxification for this patient?
Well, in detox, we certainly would like to, address her, increasing cow score. I mean, she was positive for, I can't remember. I know tramadol and maybe fentanyl as well. So we certainly would use a cow score on her. And I've been using more and more, as more studies come out that people have been having precipitated withdrawal with fentanyl. If I see them personally, would try to microdose the patient at some point when there was observable cow scores with buprenorphine, most importantly. And then, of course, using a CEWA or a modified, benzodiazepine version. And you never really know how much benzodiazepine these people get when a lot of them are mostly fentanyl or whatnot. So we'd also observe that, and during detox, put the patient either on a diazepam tape or even a scheduled amount, and look for, symptoms decrease, at least early on. But certainly the patient could have anywhere from mild symptoms during detox or serious, really depending on, exactly what's in her drugs when she takes them and how much she's taken them, how long.
Right. These are very challenging patients, high risk, I think, from a medical legal perspective, even because a lot of times people will say that they're using 4, 6, or 8, but maybe there's not even a benzodiazepine in the tablets at times, I've found. Sometimes it's intermittent, and you've really got to go by symptom-based, and reassessment is key. So both over-treating and under-treating can be a problem. The many nurse practitioners contacted an area medical toxicologist, addiction provider, and I mean, this is a patient I prefer to use phenobarbital in the hospital, but that's not available. So we had started diazepam 10 milligrams 4 times a day, decreasing by 10 milligrams every 2 days. And if symptoms of withdrawal escalate rapidly, recommend sending to the hospital for higher level care. Buprenorphine is available, and clonidine hydroxyzine and valproic acid 500 milligrams twice a day for 15 days as an adjunctive taper. We're going to skip this. We've already talked about the detoxification regimen. This is really more about the surveillance. If anyone has any additional questions or comments on the regimen, please email me afterwards. The patient tolerated the withdrawal regimen, and we did dose as best they could in the facility a buprenorphine microinduction using a half of it twice, about 24 hours after presenting, followed by a 2 milligram dose twice, which she tolerated well before increasing to an 8 milligram dose twice a day. She remained on valproic acid for 15 days and was referred to outpatient detox after completion, and continued on the valproic acid outpatient. Mood stabilization properties working well, and considering subcutaneous buprenorphine doing well. So is there any final quick comments? We're essentially at time regarding the psychoactive, novel psychoactives. Dr. Logan, any final comments you want to add? I think you're muted.
Just to reinforce that these drugs are changing all the time. We have a collaboration with the Society of Forensic Toxicologists and International Association of Forensic Toxicologists where we publish every quarter a list of the most prevalent, most prominent NPS drugs, and these are on the NPS Discovery website.
Yeah, that's great. I think I had an alert via email as I was preparing for this just a little bit ago from NMS about a novel psychoactive. Dr. Brent, do you have any final comments?
I think we're pretty much out of time, so I'll pass on any more comments.
Dr. Bishevitz, is there any final pressing questions from the audience?
No, we've taken care of all of them.
Okay, very good. And I almost finished with a final thought, and this is from Hayden Carews, called This Decoration, from Collected in Shorter Poems, 1946 and 1991. And it is blue light, morning glory color driven through green fir brose. So it was bright as crow caw on the next to last day of October. You've given me this decoration made from dried pasted flowers inside the cap of a cottage cheese carton. Beautiful flowers, unrecognizable, flowers that would stare with blue-green feeling, delighted and ignorant. Till you tell me you made them up. One is scales from a pine cone, flattened with a tuft of silverrod seed fluff in the center. Another is from a dried panicle of millet with petals of maple seed. Now I see burrs, bark, a snip of duck feathers. How exquisite flowers of imagination from this real world made and given for loving kindness. I go out wordless, walking the stubble rows, and here nigh comes this black crow, above the furrows high and straight, flapping as if from a great distance from eternity. Caw, loudly, and back from beyond the firs comes the answer. Caw, way off, far, although near to and wordless, as real things always are. And one more thing from Loading Mercury with a Pitchfork, Richard Brodigan, passed away in 1984, called Postcard. I wonder if 84-year-old Colonel Sanders ever gets tired of traveling all around America talking about fried chicken. Loading Mercury with a Pitchfork, Richard Brodigan. Some upcoming events, mark your calendar for the New York Society of Addiction Medicine annual virtual conference, the 11th and 12th of February, the 11th in the afternoon, Public Policy Day, and the main Congress, including the toxicology panel. Dr. Brent and Dr. Logan, as well as Dr. Sullivan, are going to be participating in the panel, including a couple of others, and we will be covering more toxicology. You can see some additional events at NISAM.org. There's also a couple of other webinars that are available to the public, including a cannabis series, and we have an upcoming pediatric cannabis exposure that's available through registering at the NISAM website. And then again, a reminder in the seminar in forensic toxicology, look forward at new psychoactive substances and a look at BAC at ethanol. Virtual conference December 16th and 17th. Our next toxicology webinar is January 14th, so not the first Friday. And I wish everyone happy holidays, and thank you for joining us today. And I want to thank my panelists as well. Have a good afternoon.